The four clinical scenarios in which you will encounter metabolic alkalosis the most are volume depletion, especially those due to vomiting or overdiuresis, volume overload, especially those being actively diuresed, and chronic respiratory acidosis, chronic CO2 retention, when CO2 is acutely reduced with BiPAP or mechanical ventilation. This is what we call post-hypercapnic alkalosis. This happens if there was associated stimulation for bicarb gain or retention, and typically the presence of volume depletion in these patients, and for iatrogenic from bicarbonate therapy, oral or IV. Metabolic alkalosis, the serum bicarb, which is labeled CO2 and BMP or CMP, will be above 26 milliequivalent per liter, plus absence of primary respiratory acidosis. If you're not sure if there is a primary respiratory issue or not, obtain an ABG. But in most cases, the history is enough to tell you if this is just pure metabolic alkalosis or a compensation of primary respiratory disorder. In order to develop metabolic alkalosis, you need two things together: bicarb gain plus sustained renal bicarb absorption. The kidney is so powerful that any excess bicarb in the serum will be excreted in the urine to keep the bicarb between 22 to 26. If it becomes anything above 26, the kidney will be able to excrete it to keep it within this tight range. So first of all, you need something to make you gain bicarb, whether indirectly by hydrogen ion loss. Remember, hydrogen ion loss mean bicarb gain. Hydrogen ion gain mean bicarb loss. Or true bicarb gain. Plus sustain that the kidney is not excreting this excess bicarb in the urine. This is either because of abnormal retention, that the kidney abnormally retaining that bicarb instead of excreting it, or there is too much bicarb load, that the kidney is still excreting the bicarb, but there is still excess bicarb in the serum despite that. This is a very important picture that you must know if you want to excel in nephrology. But I want you to focus here, the pump here. Most of the bicarb filtered by the glomerulus absorbed. It goes hand in hand with sodium, anion and cation. This process here is potentiated or stimulated by decreased effective intravascular volume, whether from volume depletion or volume overload. Also by hypokalemia, very important, and by increase in the partial pressure of CO2. And remember, acetazolamide block this process, allowing the bicarb to be excreted in the urine. Now, also I wanted to focus here on the hydrogen ion here. Any process that potentiate this, that means loss of hydrogen ion, which means, as we said, gain of bicarb. And anything block the process will lead to the opposite. So if more of aldosterone will lead to that, right? So primary hyperaldosteronism, for example, will lead to more bicarb gain and more hydrogen ion loss. And remember, this is blocked by Spironolactone, Amiloride, and Triamterene. So they lead to hydrogen ion retention, which means bicarb loss, right? Now, hypokalemia, very important. Almost always metabolic alkalosis associated with hypokalemia. The point here, any condition that lead to hypokalemia can lead to metabolic alkalosis. So remember, in any metabolic alkalosis, check potassium and check magnesium and replete aggressively. Without repleting, without adequate repletion of potassium or magnesium, you will not be able to correct the metabolic alkalosis. Before we continue, if you want to receive a summary of this video, please subscribe to my Substack. The link is provided below. Treatment. The treatment mainly is to treat the underlying cause that will stop the bicarb gain and to allow urinary bicarb excretion, and please discontinue any bicarb treatment or bicarb precursor supplements like acetate or lactate. Very important, adequately and aggressively replete potassium and magnesium. And please use potassium chloride. Avoid using potassium lactate or potassium acetate, because acetate and lactate metabolize in the liver to bicarb. Now for volume depletion, it's very simple. Fluid resuscitation with normal saline. And this kind of metabolic alkalosis related to volume depletion, we call it saline responsive or chloride responsive. And if it happens, you check their urine chloride, it will be less than 10. Some people use this to decide if the metabolic alkalosis is going to be saline responsive or chloride responsive or not. But to me, history and physical exam way more useful and quicker to decide. Just give fluid resuscitation and you can check the response to that. Now, fluid overload, basically these people will be getting loop diuretics already, And then if the bicarb 26 to 35, then we add spironolactone or amiloride. Now, if the bicarb is above 35, we need to eliminate larger amount of bicarb, and acetazolamide is more effective in this. Now, as we explained, acetazolamide will lead to, by inhibiting the carbonic anhydrase, by blocking the carbonic anhydrase inhibitor will lead to loss of bicarb. The same thing, spironolactone, amiloride, or triamterene, they will block the excretion of hydrogen ion, which means loss of bicarb in there. Let's compare them together. The bicarb urinary loss with acetazolamide is strong, while weak here in spironolactone or amiloride. The diuretic effect is modest with acetazolamide and weak in spironolactone and amiloride, and effect in potassium potentiate hypokalemia here and potassium sparing here. So if you using IV loop diuretics and you have metabolic alkalosis and you need to add something, if you still need more effective diuresis or to augment the diuresis of the patient, it's better to add acetazolamide as it gives you modest diuresis effect. Compare here it's weak, but remember it potentiate hypokalemia, can lead to dangerous hypokalemia. You need to replete potassium adequately. Now, post-hypercapnic alkalosis, you have a patient with, let's say, COPD exacerbation, their CO2 typically 70, you put them on BiPAP or mechanical ventilation, and suddenly their bicarb goes from 70, for example, to 40 within 2 hours, for example. So what's going to happen to the CO3? Let's say it was 35. The kidney typically will try to excrete now this excess bicarb because the CO2 is 40. But if there is a reason for the kidney to keep the bicarb, and most of the cases this patient has volume depletion. So what we do most of the time, we simply resuscitate them with IV fluid with normal saline, replete magnesium and potassium, stop their diuretics, and slowly their bicarb will correct back to normal. Now, other cause of metabolic alkalosis that you will rarely see, renal failure. We always say renal failure lead to acidosis, but rarely it may lead to metabolic alkalosis instead. And usually these patients in advanced renal failure and need dialysis, so consult nephrology. Bartter syndrome, we said it's equal as if you give somebody loop diuretics, causes hypokalemia, and it can cause metabolic alkalosis. Replete potassium and add amiloride or spironolactone. Gitelman, as if you give thiazide diuretics, again potassium repletion and amiloride. Cushing syndrome, it's not, we cannot talk about the treatment here, but you need to treat Cushing syndrome. Liddle syndrome, the same, potassium repletion and amiloride and triamterene. And primary hyperaldosteronism, you can give spironolactone. Rarely you will encounter any of these disorders, and you can just look them up. Let's take some clinical scenario. Patient scenario: one patient is on IV furosemide 40 mg IV Q8 for severe fluid overload. This is the BMP here. As you see, the bicarb is 39. Of course, I did not give details, but this we're going to assume this is metabolic alkalosis, right? There is no respiratory issue. This guy has no COPD or any reason to make us suspect CO2 retention. So there is hypokalemia and there is this bicarb 39. If this patient still needs more effective diuresis, of course you need to replace the potassium, check magnesium and replete it if it's deficient, and add acetazolamide. And this is similar to the example I put on YouTube, because the bicarb is high above 35 and the patient still needs more diuresis. Now, if let's say you decided to give spironolactone, it may work, but will be slow in dropping this bicarb here. So acetazolamide will be way more effective. Septic patients with severe high anion gap metabolic acidosis started on bicarb drip on day 1. On day 3, lactic acid was normal, but the BMP showed this. So you see the bicarb now is 27, and the anion gap, again, I told you to calculate anion gap in every BMP, and on all these BMP, the anion gap is normal. Replete potassium, check magnesium and replete it if deficient. And here it's clearly this is iatrogenic. This bicarb drip should have been discontinued from the day before even. So you need, whenever you are on bicarb drip, you need to monitor the bicarb level. So this is iatrogenic, just stop the bicarb, and that's why the patients probably have some hypernatremia. The last scenario here, patients with vomiting for 2 days found to have small bowel obstruction, had NG tube connected to low intermittent suction, BMP on day 2, 32. You can see the bicarb is 31. There is hypokalemia. Replace the hypokalemia. Check magnesium and all. And here, this is likely related to the vomiting and the NG tube suction, right? So simply, this is likely saline responsive metabolic alkalosis is fluid resuscitation with normal saline, and of course, treat the underlying small bowel obstruction. In the end, thanks for watching. If you find this video useful, please give us a like, share it with your colleagues, and subscribe if you have not done so. And make sure also to subscribe to my Substack to receive a summary of this video and to check all the previous videos summaries. Thanks for watching and see you soon.